I'd like to introduce here, I'm extremely proud to introduce the first speaker, who is Dr. Robert Kyle. He's our first speaker, and he's going to be leading off this roundtable. Dr. Kyle serves as Professor of Medicine, Laboratory Medicine, and Pathology at the Mayo Clinic in Rochester. Additionally, he served on the William H. Don Professor of Medicine and Laboratory Medicine, and was section head and chairman of the Division of Hematology. After earning his medical degree at Northwestern University, Dr. Kyle took his residency training medicine at the Mayo Clinic. He also then had a research fellowship in hematology at Tufts University in Boston and a postdoctoral research fellowship from the NCI. So his training is truly exceptional. He's truly an exceptional individual. Today he's active on many advisory boards and boards including the Board of Directors and the Scientific Advisory Board for the International Myeloma Foundation, among many other recent positions. Dr. Kyle has contributed greatly to the field of myeloma research over the years. He's got more than 800 articles and book chapters, as well as 1,100 microscripts. A copy of his CV that I came across recently lists for 127 pages, and that does not include his lectures, and it actually ends in 2008, so he's an extremely well-published individual. As a story I like to tell, to prepare for this presentation, I typed the word in PubMed, Kyle. Before I could even get to the E, the recommendations were Kyle myeloma. Click on that, you get 2,971 entries, of which 237 are review articles. So this is truly a man who's published extensively in the realm of myeloma. So therefore, it is truly my great pleasure to introduce Dr. Robert Kyle.
Thank you very much, Dan, for those kind words, and to Barbara, who has organized this entire meeting today and tomorrow, and actually in years past. I want to mention to those of you who will be attending tomorrow that my presentation today is not identical to that of tomorrow. I've been asked today to talk about about an overview of multiple myeloma as seen from the clinical trial standpoint. These are my disclosures. They're mainly disease monitoring committees. When we look at patients with multiple myeloma, we attempt to divide them into groups from the standpoint of their overall prognosis, high risk, intermediate risk, and standard risk. Those patients who fall into the high risk category are patients who, on fluorescence in situ hybridization, FISH, have a deletion of 17p or a translocation of 1416 or 1420, or have the gene expression profiling, the GP70 high risk signature. The intermediate risk patients are those who have a translocation of 414 with FISH or with conventional cytogenetics, have deletion of chromosome 13 or hypodiploidy. A very high plasma cell labeling index, that is over 3% or greater, also places the patient in this category. The standard risk patients are those who have hyperdiploidy on conventional cytogenetics, on FISH, translocation of 1114 or 614. Approximately 75% of patients with multiple myeloma will fall into this, oops, gotta be careful what I touch here. Doubly careful. about 75 to 80% of patients with multiple myeloma will fall into the standard risk group, and the remainder are about equally distributed between the high risk and the intermediate risk. Now, we first of all decide, with the input of the patient, of course, as to whether they are transplant eligible or not. And then we look at the patients based upon their risk status, and for those, the 75 or 80% of the total who have the standard risk features, one can treat with RD, Revlimid, or lenalidomide, and the small d is giving dexamethasone 40 milligrams weekly. I hesitate to call that low-dose dex, although many people do, because 40 milligrams of dexamethasone is a very large dose, as those of you who have taken it know. The other option is a combination of bortezomib, that is Velcade, dexamethasone, and cyclophosphamide, Cybor-B. After these 4 cycles, the stem cells should be collected for those patients who are transplant eligible, and then the patient has the option of proceeding with the transplant as soon as they have recovered from the stem cell collection, or if things are going well and they prefer to be treated, that they continue with the chemotherapy. We generally recommend an upfront transplant because following this, the patient will have obtained a complete response or a very good response, or at least a partial response in the vast majority of patients. For those patients in the high-risk group seen on your left, we recommend a combination of V for Velcade, R for Revlimid, that is bortezomib and lenalidomide, and the weekly dexamethasone. After 4 cycles, the stem cells should be collected, and we generally go ahead with an autologous stem cell transplant, and then recommend a minimum of 1 year maintenance with a combination of the bortezomib and the lenalidomide. The bortezomib to be given at weekly intervals. That's one of the most important recent pieces of information that has become apparent within the past year. That is, patients taking the bortezomib at weekly intervals have approximately the same benefit as those patients who take it on the standard dose of days 1, 4, 8, and 11. The incidence of sensory motor peripheral neuropathy is much, much less in those patients who receive the weekly bortezomib. If the patient is in the intermediate risk group, we recommend 4 cycles of the Cybor-D, and then an autologous stem cell transplant, and then we would generally give bortezomib weekly for a year.